Good afternoon to respected director sir, Dr. Jaya Shree, and all the viewers on the ISFCP platform. So today we have among us Dr. Jaya Shree. She is working as associate professor at Shri Shankracharya College of Pharmaceutical Sciences, Vilai, Chhattisgarh. So, as per introduction of Dr. Jaya Shree, Dr. Jaya has completed her master and PhD from Guru Ghasidas Central University, Bilaspur, Chhattisgarh, and her specialization is pharmacology. She has published more than 30 research and review articles in her field, and she has also many patents and book under the field. Uh, today, Madam going to deliver her lecture on diabetic cataract. So I request to Madam, please continue.
Thank you so much, ma'am. Thank you so much, Director Sir, ISF College of
Welcome,
Pharmacy,
welcome, madam.
Moga. It's a great privilege to me for being a part of this lecture series. This is Dr. Jaya Shree, currently working as Associate Professor in Shri Shankracharya College of Pharmaceutical Sciences. And my topic of presentation is diabetic cataract, pathophysiology, and its management. So, starting with the introduction of diabetes, it's a group of metabolic disease characterized by chronic hyperglycemia. I hope my presentation is visible to everybody.
Yes, ma'am, it is visible.
Yeah. Okay. So it's a group of metabolic disease characterized by chronic hyperglycemia resulting from defects in insulin secretion, its action, or it may be both. And the symptoms of diabetes are polydipsia, polyuria, polyphasia, etc. And it also weakens the immunity. So actually, it is a metabolic abnormalities in carbohydrate, lipids, and proteins. According to a study, the number of people with diabetes rose from 108 million in 1980 to 422 million in 2014, and the prevalence is more in low and middle income countries than in high income countries. And according to the International Diabetes Federation, it estimates that till 2030 there will be 439 million diabetic mellitus patients. It's a major cause of blindness, kidney failure, heart attack, stroke, and lower limb amputation. So diabetes mellitus, it is associated with so many secondary complications, like it causes microvascular and macrovascular complication. Microvascular complication means it causes the damage to the small blood vessels, like it affects the kidney, it causes nephropathy. In eye, it causes retinopathy, and it also damages the nerve. And macrovascular complication means it damages the large blood vessel, and it includes blood vessel, arteries, and veins of the
Ma'am,
heart.
ma'am,
Yeah.
slides are
Yes.
not moving.
Okay. Okay. Ma'am,
Okay.
now. Ma'am.
Yes, it is okay.
Okay. Okay. So secondary complication of diabetes are two types: microvascular and macrovascular complication. Microvascular complications like damage of small blood vessels, like kidney disease, nephropathy, retinopathy, and neuropathy. And macrovascular complications means the damage to the large blood vessels, like blood vessels of arteries, veins in the heart. So this is the figure. Uh, this figure depicts about various secondary complications of diabetes, like it affects the eye and causes the retinopathy and cataract. It affects the kidney, nephropathy. It causes peripheral neuropathy. It also affects the heart. It affects the brain. It affects the bone, fatty liver disease. It can cause, etc. So among these disorders, I will mainly focus on the diabetes associated eye disorder, and under eye disorder, I will mainly touch the cataract. Diabetes mellitus causes the cataract, and What is cataract? Is a leading cause of visual disability and blindness, and now it affects 80 million people worldwide. Actually, it affects the deteriorates the quality of life. It's a multifactorial disease characterized by cloudiness and opacification of the eye's lens, mainly due to formation of large protein aggregates around the lens. So, as the prevalence of diabetes mellitus is increasing, so the incidence of diabetic cataracts is also rising. And the only available treatment till now of the cataract is the surgical removal of the natural lens, and it replaces with the synthetic clear lens. Here I can show like this is the diagram showing the normal and lens and cataractus lens, and normal eye and the cataractus eye. And this image I have taken during my PhD tenure. So there are three types of cataract mainly. uh, what happens when the opacification is there in the nuclear region or nuclear part is known as nuclear cataract, and when the opacification is around the cortical area it is known as cortical cataract, and when the opacification starts from the back of the lens then it is known as posterior subcapsular cataract. So here I am showing the features of the nuclear cortical and posterior subcapsular cataract. Like nuclear cataract, the symptoms are blurred vision. Obviously, there will be loss of vision, loss of blue-yellow color perception. And in the cortical cataract, what happens? Difficulty in reading. And in posterior subcapsular cataract, there will be impaired near vision. And the causes are UV radiation, oxidative stress, ionic imbalances, and systemic disease. And under systemic disease, diabetes is the most commonly it is causing the cataract. And in this slide, I'm showing the pathophysiology of diabetic cataract. It is of if it is related with the diabetes, there is three types of pathophysiology. First is oxidative stress, polyol pathway, and non-enzymatic glycation. So, in the next slides, I will deal with these pathways. First of all, oxidative stress, oxidative cellular damage. What happens? The exogenous and endogenous stress factors like ultraviolet light, drug, peroxisomes, and in diabetes cases the excessive glucose in the blood it causes the proteins to get oxidized. The oxidized protein gets accumulated inside the lens, and protein aggregates around the lens, and uh, it causes the exacerbation of the cataract formation. Obviously, there are the defense system in the body, antioxidant defense system and repair systems are there. But if it fails, the defense system fails, then certainly the cataract will happen in the diabetes cases. And the most important pathophysiology is polyol pathway. What happens in polyol pathway when there is excessive blood glucose level? So the glucose in the presence of enzyme aldose reductase gets converted into sorbitol, and sorbitol further with the help of enzyme sorbitol dehydrogenase gets converted into fructose, and the increased amount of fructose increases the osmotic stress. It also increases the reactive oxygen species, and it forms a advanced glycation end product, and ultimately it causes the cataract formation. And in the non-enzymatic glycation pathway, what happens? The glucose, excessive glucose in the blood, somehow it mixed along with the proteins, amino acids. It rearranges somehow, and it forms the advanced glycation end product, increases the number of free radicals, reactive oxygen species inside the eye and the lens, and further it exacerbates the cataract formation. So these are the pathophysiology of cataract formation. So this is very important. The prevalence of cataract in diabetes patient. So cataract formation occurs more frequently and at earlier age in diabetic patients than in non-diabetic patients. Means diabetic patients are more prone for cataract formation, and this is 3 to 4 times more prevalent with the diabetes patient under the age of 65. So there are so many treatment for diabetic cataract, or first is surgery. This is the only available treatment. All the people are going for this surgery only, and it is not cost effective. And there are so many post-operative complications are there, like endophthalmitis, infection, swelling of the retina, posterior capsular opacifications are there, and also it is very costly. And the recent trends are that to find a novel drug like aldose reductase inhibitor drug, antioxidant, and non-steroidal anti-inflammatory drugs somehow delay the cataract formation. And the most suitable route is ocular route, via it should be given via ocular delivery system. But through the ocular delivery system, there are so many obstacles are there. First barrier is cul-de-sac. So what is cul-de-sac? It is a shallow pocket in the lower eyelid where palpebral and bulbar conjunctiva meet in the lower eyelids, and the maximum capacity of cul-de-sac is only 30 microliter in humans. But the regular movement of the lower eyelid to its regular position, it reduces its capacity to 70 to 80%. And the inflammation and allergic responses of the eye also minimizes the capacity of cul-de-sac. Actually, via the ocular drug delivery system, the bioavailability of the drug is only 5%. The bioavailability is very less, and because of these barriers, first is cul-de-sac, and second is loss of drug from lacrimal fluid. So as soon as somebody puts a drop on the eye, obviously the loss of drug from lacrimal fluid could happen as a result of lacrimation, solution drainage, and non-productive absorption in the conjunctiva. So these are barriers. And apart from this, the corneal barriers are there, because the cornea provides a resistance obstacle to any chemical and mechanical injury, and it is divided into epithelium, stroma, and endothelium. The epithelium is formed of 5 to 7 layers of firmly linked cells. Stroma is a water-based compact layer. The epithelium is a barrier for hydrophilic drugs and the large molecule, whereas the stroma is a barrier for lipophilic drugs and the small molecules. So cornea also offers a resistant resistance to the drugs. And also there is blood ocular barriers. So the blood ocular barrier, it is classified into blood aqueous barrier and the blood retinal barrier. Blood aqueous and blood retinal, when they also restrict the drug, and it does not allow the drug to move inside the eye. Wherever you want to, actually you want the effect on the eye. So these are the barriers. But there are so many methods to overcome these barriers. One can improve the bioavailability by adjusting the viscosity of the drugs, and the permeation enhancer can also be included, and the pro drug can also be used. And the novel drug delivery systems are there, like implants, inserts, microparticulates, and the colloids. So all these barriers, and we can formulate so many doses form. Among them, the eye drops are the most common form of liquid ocular drug delivery system. Eye drops are often used to manage symptoms associated with cataract, such as dryness, inflammation, or discomfort. So it is the most conventional type of drops, the dosage form, ocular dosage form. And second one is injectable intraocular solutions. So what happens in the cataract surgery? An intraocular solution is injected into the eye to maintain its shape and provide anesthesia. So these solution may also contain medication to prevent infection, like the posterior subcapsular infection, and it also reduces the inflammation or manage other post operative complications. Ocular inserts are there, like these are small devices placed in the lower eyelid conjunctival sac, releasing medication slowly over an extended period. These inserts are commonly used for conditions such as dry eye syndrome, but their application in cataract treatment is limited. Nano emulsions, drug delivery systems are there. Advanced drug delivery systems such as nano emulsions and nanoparticles are being investigated for targeted drug delivery directly to the lens and the surrounding tissue. These systems they utilize very small particles or emulsions to improve drug penetration, its bioavailability, and allowing for more efficient drug delivery to the effective areas. Next is semi-solid ocular delivery system. Under semi-solid ocular delivery system, gel-based systems are there, ointments are there, and these are gel based system. It is hydrogels or in situ gels. In situ gels are what they transform from a liquid to a gel upon application to the eye. They can provide the sustained drug release by incorporating the active pharmaceutical ingredient within the gel matrix. The gel can adhere to the ocular surface, and it facilitates the prolonged drug contact and its absorption. Ophthalmic ointments are there. These are also semi-solid drug delivery system, a dosage form, and it contains a base such as mineral oil or petrolatum along with the API. And ointments offer longer contact time with the eye, enabling extended drug release. However, they can cause blurred vision temporarily due to their greasy nature. And the inserts or implants are there. They can be solid or semi-solid devices inserted into the eye to provide the sustained drug release. They can be placed in the conjunctival shaft or within the anterior chamber. These inserts gradually release medication over an extended period, providing a continuous therapeutic effect. And obviously the solid ocular delivery system for cataract is also there, like ocular insert for these small ocular pellets or small drug containing devices that are placed in the conjunctival sac. Ocular inserts can be made from biodegradable polymers that gradually dissolve in the eye. They release the drug slowly and over an extended period of time and provide sustained drug delivery system. Further, we have nanoparticles. They can be used to encapsulate drugs and enhance their delivery to the eye. They are typically composed of biodegradable or biocompatible materials and can be engineered to release drugs in a controlled manner. And contact lenses are there. Drug eluting contact lenses are another approach for ocular drug delivery system. These contact lenses are designed to release drug directly onto the ocular surface. The drug can be incorporated into the lens material or loaded onto the surface of the lens. Contact lenses provide prolonged drug release and can enhance patient compliance due to their ease of use. So these are the different drug delivery system. So future perspective of these are that the extensive research is needed in the area of diabetic cataract, and so that to delay the cases of cataract or completely inhibit with the drug so as to avoid the surgery and increase it can also increase the patient compliance, etc. So these are my references. Thank you.
So, thank you, Dr. Jaya, for this valuable talk, and I hope this will be beneficial for all listeners. And it is requested to all the viewers and listeners, please put your comment or queries regarding this lecture in the chat box, if any, and definitely we will reply your answers on our hand or by consulting with the expert. So finally for some of the session, I invite our respected director sir to say a few words. Please sir. Hello. Uh,
So thank you very much, madam. And
Thank you so
you
much,
have
sir.
given a very specific information. And one of our colleague and professor, Dr. Siddharth Manji, he is the pharmacologist
Yes, sir.
present over here and the coordinator of the IIQAC. And
Yes, sir.
under this IIQAC, he is the taking care of this ISF dialogue series. So, madam,
Yes, sir.
as you know that we have the excellent department of the pharmacology, and
Yes,
our
sir.
team is the doing the work in the various you can say specialization. So I hope that, but most of the people's one of the candidate they are doing the work on the you can say ophthalmology or related to the eye. So I hope that in the coming days this field is the one of the very important and specific and useful in the future over here. So thank you very much, madam, for accepting our invitation and
Thank you
provide the
so much, sir.
opportunity to interact to this one. Now I request you, Dr. Siddharth
Thank you so
Manji,
much, sir.
to give your specific comment and thanks to the madam, please.
Thank you so much, sir. It really means a lot. Thank you so much.
yes sir. Sir, you are mute. Hello.
Thank you, Jia ma'am. Thank you so much for this excellent information, and we
Thank you
highly
so much, sir.
appreciate that you joined us today. Thank you so much.
Thank you so much, sir. Thank you so much, sir.
Thank you.
Thank you sir. Thank you Dr. Jaya.
Thank you, ma'am. Thank you so much.
Okay.
Preeti ma'am, please stop the recording before leave the meeting.
Yes sir.
Okay.